Okay, well, thank you very much to Dr. Niazi and Heather. This is great, and the University of Miami. So we had it. So Dr. Drake was sort of going to cover like where we've been, and then I'm going where we're going in the future, kind of. But for scheduling, we're going to switch the order here. So I'm just going to talk about the role of the HCRN, the Hydrocephalus Clinical Research Network, and the recent advances in the pediatric hydrocephalus research. Okay. Before that, any disclosures? I have nothing personal to disclose. And then the HCRN is funded by PCORI, NIH, and various foundations and private philanthropy, and the HA. So just to get everyone oriented, so the HCRN is a research network of 14 universities and children's hospitals from across North America, 3 in Canada, 11 in the United States, and the center hub, the data coordinating center, is in Utah. That's why they get 2 stars there. So great. And so right now, to summarize basically what's going on in the HCRN, there's 3 major streams of research: shunts, post-hemorrhagic hydrocephalus, and ETV-CPC. And so I'll just kind of expand on that a little bit more. So we'll start with, those are 3 mantras. Our mantra, our goal of the HCRN is improve the outcomes of children with hydrocephalus. And so let's start with shunts. And so it all starts, the beginning is that the very first sort of thing we got together as a group of 4 centers and started using the Toyota model for building cars, but for shunts. And basically, it's the birth of the quality improvement era, or quality assurance. And we want to prevent shunt infection. And so how do you do that? We came up with a shunt protocol we kind of all agreed on, otherwise known as a checklist. And you do that by reducing variation. And when you reduce variation, the car companies and every other factory in the world show that you can improve outcomes, and it also works in a healthcare environment. So this is a study spearheaded by John Kessel, who's also the founder, the co-founder of the HCRN. And so this was the original shunt protocol, which doesn't seem that long ago, but that's 2011 we published it. So the network started 12 years ago. That also ages me. And so again, 4 centers, prospective design. And then when we went to look, before we started getting together and agreeing to follow the checklist, our infection rate was almost 9%. And then afterwards, it was 5.7%, which is absolute risk reduction of 3% and 35% relative. And our compliance is pretty good. And compliance in these sort of studies are good is like 60%. So 75 is pretty good. Along the way, when you do a checklist, you can kind of mix and match and start looking at risk factors. And we found something clear in the literature that there is people who scrub with Avogard instead of a formal scrub were increasing the infection rate tremendously by a factor of 4 almost, and so by an odds ratio of 4. And so that is now banned for shunt use in the HCRN. The nice part about the protocol is that we also see this is not an HCRN center, but a study we did when I arrived in Calgary. So at that time, we were not an HCRN center, and the infection rate was about 12.7%. And then before my arrival, they had started using the HCRN protocol as it was published and dropped to 2.7. So I only just show this because it shows the implications of that. It's not just big major centers or centers within the HCRN. Other centers outside the HCRN can use this and see improvement in their numbers. Again, pretty good compliance. And then this is birthed, you might hear, sometimes I talk about the HCRN-Q, which is the new wing of the HCRN. So we have the center for 14 centers that do the studies. And then the Q arm is the one that to look at implementation of the results that the center HCRN discovers. And so I think there's 14 HCRN centers, and I think 32 HCRN-Q centers. Again, there's a ripple effect, the shunt protocol. So when we instituted this in Utah, we saw that all of our, when we went to a shunt protocol, all of our implant infection rates went down. And here we just saw for ventricular access device or reservoirs, you were not required to use the protocol, but it still dropped our infection rate from 15% to 5%. So the second version was in 2016. Now this one's of interest because we simplified the shunt protocol, and the thing, we took out injecting the shunt with Vanc and Gent, and we put in antibiotic impregnated catheters. That was the big change. And now we had expanded to 8 centers, and again, this was a prospective cohort study. You're going to see that theme throughout. So our compliance, you can see there, is good and increased over this census study, which is great, and our infection rate stayed low. And the bottom line is the protocol. On this protocol, we had an infection rate of 6%. So without any protocol, we were at 9. With the first one, we were at basically 6, and with antibiotic impregnated catheters at 6. So the natural conclusion there, it doesn't matter if you use an antibiotic impregnated catheters or you inject regular catheters with Vanc and Gent, there it seems this similar impact. And currently we're on a 3rd QI study protocol. We've changed it one more time. So this again is not an HCRN study, but obviously an important study. So the British investigators in the BASIC study, again, a multi-center single randomized control study comparing 3 arms, silver, antibiotic, and standard, showed that there was a significant improvement or decrease in shunt infections with antibiotic impregnated catheters there, you can see, but not with silver. So, and again, that's a prospective randomized control, 21 centers, again, non-HCRN. So that fits, that sort of dovetailed nicely. So we have North American numbers hinting that the catheters, and then definitive European numbers clearly showing that antibiotic impregnated catheters improve shunt infection. So, but we want to attack this problem at multiple angles. And so how else can we improve the shunt? We got to figure out what the risk factors for shunt infection are and then avoid them. And so this is a prospective study led by Tamara Simon and myself, and published in Journal of Peds a while back now. So this is 1,000 children prospective. We used the common definition. The HCRN, you might say, well, your infection numbers are like higher than ours, but the infection definition in HCRN is pretty rigid, including pseudocysts and exposed hardware, whether they're in growing bugs or not. And we looked at 36 different risk factors. I'm sorry, 26 different risk factors with 36 complements, and found that the presence of a G tube was significant. But the most important risk factor was a revision procedure. So to avoid a shunt infection, the best thing you can do, and this is pretty self-obvious, but is to avoid shunt revision. So if you have 1 shunt revision, your hazard ratio increases by 4, and 2 or more by a factor of 13. So if you really want to fix shunt infection, we got to fix shunt revisions. And again, 6-center prospective cohort study. So very simultaneously, this study, same cohort of 1,036. And so what are the risk factors of shunt failure? And so if we know those, we can avoid them. So these are children with the first shunt placed. And again, I should just say the outcome was shunt malfunction, and that could be obstruction, infection, fracture, misplacement, anything that led the surgeon to fix that shunt. And this is what we found after a multifactorial or multi-variable analysis, and showed a couple of things that we can't fix, like age less than 6 months, that always shines through. Is still a risk factor. Interesting, a cardiac comorbidity, which another group had previously reported on, and we've confirmed that that's the case, and we continue inquiry on that. And then one thing is the use of the endoscope to place the shunt was increased your chance of shunt obstruction. That's a little hard. That's an adjunct you're using to theoretically increase the life of your shunt, but in our study, it clearly showed that it decreased. And we weren't the first, so obviously the endoscopic, the ESIT trial led by Kessel and Drake way back when, that randomized control study showed no difference. And in fact, there was a trend that the endoscope hurt. And so this fits with that trend. And then what about the age-old thing, but one valve over the other, or programmables versus non-programmable? Those all were found not associated with shunt failure. So again, 8-center prospective cohort study. So after doing all these studies and learning what the risk factors are, and then getting the word out there, and then changing our practice, has it changed anything? So this was early on in the life of the HCRN. In 2013, Kulkarni published this and showed that our historical numbers in the shunt design trial and the ESIT trial are in blue, and the HCRN numbers are in red. And so we were seeing some improvement. That in the old days, it's 60% of shunts malfunction at the 2-year mark, and this study in 2013 said it was 40%. I could say we're just doing another study, we're looking at it, and this is now dropped to about 25%. So there's a lot of hypotheses for that, but I'll get to that in a minute. So prospectively collected data, 7 centers. So here's the most recent, and this will be published on Wednesday. Mandeep Tamber was the lead on this in the HCRN. So this is 2017 data. And so taking out of our registry 9 centers, 9,000 procedures in 5,000 patients. And so prospectively collected. And so this study was sort of to zoom out. We started noticing trends in the HCRN, and to zoom out and see if these trends that we were noticing actually are real, and they are. And so one thing we saw is that the incidence of hydrocephalus, or requiring a shunt anyway, is decreasing by about 9% a year, which is pretty substantial. So some of that is the birth of the ETV-CPC, and more and more end up in ETV, so less shunts. But when we accounted for that, it still was falling. And so some of it is just having a higher threshold to shunt patients, we think. And then decreasing shunt revisions. So this is where we really want to make an impact. And this is revisions on shunts are decreasing by about 5% per year within the HCRN. So this is good news. Finally, in hydrocephalus, we have some good news. And then what about the future for shunts? So if anyone was at the PED section, was it last week or the week before? Bill Whitehead led the entry site. So we randomized, this is a randomized control study we did the last 4 years. It got funded by Pete Corey, 448 patients. Time to shunt failure was the outcome. And he just presented that data, and it showed, and we were randomized between an anterior, or there's a posterior, and there's an anterior shunt, because we had some preliminary data that entry site was, and not the tip of the shunt, was what was driving this. And the results, the curves diverged with the advantage appearing to be anterior. However, it was not quite significant. So we are declaring that trial that there's no difference, and we'll do some post hoc analysis. But anyway, that was presented last week. 14 centers, prospective randomized control study. Okay, what about improving the outcomes in post-hemorrhagic hydrocephalus and pre-IVH? So this was led primarily by the Vanderbilt team, Jay Wellens and Shevis Shannon, who's now left the network for higher pastures. But so why does this one matter so much? It's the most common diagnosis reason or etiology for hydrocephalus in North America. This is what our hydrocephalus looks like within the HCRN, so you see it's the most common. Early on, we did this study where we looked at, we're trying to figure out which was better, ventricular access or reservoir device or a subgaleal shunt. And early studies showed that we're trying to figure out what was driving those decisions, and the decision to put a temporizing device in. Bigger ventricles, you're more likely to put it in, but also by center, which is bad news because that shows that it's not really science, it's what we're taught. And we're seeing temporization rates vary between 25 and 96%. And we're seeing like some patients, some centers keep the patients for 2 weeks and some keep them for like, 3 months. And so obviously some centers are keeping them, sending them to tertiary or secondary care places and vice versa, and some are keeping them. So the treatment for PHH varied wildly across North America. And so we decided to unitize it. So before you can study anything, you got to at least decrease the noise. So this is the soft criteria. So we all agreed that we came up with this criteria and we'd all follow it. And you had to meet criteria: birth weight, 72 hours, your ventricle size, that's the FOR, had to be greater than 0.55. And if you had 2 of 3, bradycardia, split sutures, or bulging fontanelle, then you went ahead and treated. And then you went ahead and treated what you normally treat with. If you're a subgaleal shunt person, do it. Reservoir, do it. And again, 6 centers, and Jay Wellens led this, following those protocols. And so what we found, again, not randomized, but we found that the cohorts were roughly even. Perhaps the VAD kids, the reservoir kids, were a little sicker, but not too much. That's about what we treated in terms of ventricle size. And we found no difference in the conversion rates to a shunt. So again, negative, but still learned a lot. And then what about, well, sometimes the tie goes to the one that causes less complications. And we see between death, CSF leak, and infection, they all seemed similar, or there was no statistical difference. All right, so Elvis came along. For those that, Elvis is a randomized control study out of mostly Europe, and specifically the Netherlands, and one North American city, St. Louis, and was negative, comparing low threshold, so the ventricle size on the Levine index of 97%, versus high threshold, so 97 plus 4. However, recently, and this is an article that just came out a month ago, that showed a composite death, cerebral palsy, and low Bailey scores, a 35 in the low if you intervene before the ventricles got too big, versus the 51, which approached significance, but when you adjusted for gestational age and IVH severity and cerebral hemorrhage, it became significant. So this, we heard this data already, and then when this got published and presented, there's a huge groundswell within the HCRN to change our protocol. So this is a study that's going to start soon. So we are now with the same group of kids, and instead of doing a randomized control study, no one in the HCRN is interested in looking at that low threshold. Those ventricles are very small, and what we want to compare, the historical, where we just treated based on symptoms alone, but in general the ventricles got bigger, versus their high threshold, because we thought that was more reasonable. And we're going to look at shunting rates, complication rates, their cognitive by their Baileys, and also their CSF biomarkers. So that is starting in the new year. So that's hot off the presses for the world. So that's going to be happening in the HCRN. Okay, the other hot topic is ETV and ETV-CPC. And there we can see, so Dr. Wharf, as we all know, the father of the ETV-CPC is Dr. Wharf, where he developed this as an alternative shunts in Mbale, Uganda. And this is the Cardinal article in 2005, which if you do add CPC to the ETV, after a year of age, it makes no difference. However, in children under the age of 1, you can improve the success of the ETV alone from 47 to 66. So this is in a resource-poor country that shunts are not an alternative. And so the proof of concept had to come to North America. And so Dr. Wharf, when he moved to Delaware, and then subsequently Boston, brought the technique and showed a 59% success in Boston Children's. So is the ETV is the CPC part of that success? And the data would suggest it was, because the ETV success score would have only predicted a success of that cohort of 45%, but we got 59%. So it's not quite as good as the African data. And so it sort of validated that the ETV-CPC can work in the North American population. But again, that's the founder or the discoverer of this technique. So what about everyone else? We would try it in the HCRN. We had good results, but not quite as good. Also, another center that publishes a lot here is the Miami Center. And so there's a difference in case mix, but this is a study done, I think I see her there, Shelley Wang did this, and the Abko Carney, comparing the Boston group to the Miami group. And you can see Miami's has less of a success. Now, is that because Dr. Worf is the wizard at it? Is that because Miami's doing more preemie IVHs? Probably is some part of that. And also, but one does flexible scope only and one does rigid scope. So they looked at that, and it appeared that that is an important factor. So we also did this in the HCRN early on. We looked at this, and if you can coagulate 90% of the choroid plexus, your success rate is at 82% at 1 year versus 36 if you don't. Now, if you use a flexible scope, you can get 90%, 88% of the time. I know I'm adding percentages to percentages, but if you use a rigid scope, you can only get 90% in our hands of 14% of the time. Again, those were in our hands, and this was very early on. So appears using a flexible scope appears important. I use this slide just showing how ETV-CPC has blossomed over the years and then sort of stabilized. We've now have 600 cases within the HCRN's registry, and we're doing over about 100 a year, maybe more, within the entire network. So again, we like risk factors. We like to know why things fail and why things succeed. And so it felt like there's some kids that do better than others, and we were trying to sieve those out. And so we did a prospective cohort study, 8 centers, 192 ETV-CPCs, largest in a North American population at that time. So the first factor is age, and you can see a beautiful, basically dose response for age. So children under 1 month do the worst, but not bad. So 1 to 5 months, not bad, but over 6 months, much better. And then over a year, they do really well. What about etiology? So the etiology, they all seem to do okay, except for preemie IVH, which is that dreaded purple line or mauve line there. And so based on this study, now ETV-CPC is not really offered for preemie IVH patients for most patients in the HCRN at least. So we always have to remember the other side of the coin. We always talk about success, failure, complications. So on the left is the complications for ETV-CPC. And on the right is a study done by Dr. Drake, I'm sure he'll talk about today, for just ETV alone, sort of the landmark study there. And when we look at that, we see that we have about a 3.4 to 3.6% CSF leak for both procedures. And really the complications are fairly identical. And so the CPC does not appear to cause any more major morbidity than the ETV alone. Something we all should always remember is that seizures are not infrequent afterwards, and we have a 2% success or a 2% seizure rate. You can't talk about ETV-CPC without this landmark study, New England Journal a couple of years ago, which I bring it up today mostly to talk about. You saw that there was no difference in failure rate. You can see that Kaplan-Meier curve up there on the right. But what was so landmark about this paper is that stop talking about, well, we should always talk about success, failure, but let's talk about what matters, and let's talk about their cognitive or their Bayley's 3 scores. And parents may not care if their kid gets 1 or 2 revisions. They just care that they're smarter than they could have been. And so this is the new normal, patient-centered outcomes, hence the birth of PCORI. And so looking to see if there's difference, and they did not find a difference in these patients in cognition. So this is the big study that we've just started. This is the ESTI trial. So in the HCRN, we're going to do, that was a study out of Africa I showed you from New England Journal. This is a North American HCRN. It's going to be 16 centers. It's randomized between ETV-CPC and shunt. And the outcome, the primary outcome, is just like the African study, Bayley score at 1. And we're going to follow, we have funding to follow them all out for 7 years until they're in grade 1. And we'll do a full scale IQ. And we'll also obviously look at treatment failure, biomarkers, and some radiological. We already had 4, although I just heard we had 1 this morning. We randomized, so we're at 5 now. So I'll just, some other questions that are ongoing that we talk about all the time and we're designing studies for. This study is going to be submitted next week. This is the role of ventricle size. You see somebody there on the left, big ventricles, and then they're treated. And sometimes the ventricles go down to nothing. Sometimes they stay big. And a treated big ventricles, do they do worse than not? We did some neuropsych testing on all these patients, and the study will be published probably in the early spring. Probably the biggest topic in HCRN or in pediatric hydrocephalus that needs to be dealt with is when to treat and what does a failure look like, a shunt or an ETV. That sounds like it should be pretty clear. You know, I give lectures to medical student residents, say, oh, big enlarging ventricles, OFC's breaking percentages, sunsetting eyes, that's all easy. That's sometimes how they present. But what about after you've done an ETV and the patient's doing really well, but he's still doing perfectly, but the head circumference still keeps growing? What about baby doing well, but the ventricles stay big? What about you do a myelo, everything's perfect except you got a pseudomeningocele? Was that just a crappy back closure, or is that a sign of raised pressure? And then do we agree what things like a full fontanelle are? This is a good study from Michael Dewan and Rob Naftel. It's not an HCRN study, but just looking at, it's easy when you have big ventricles, a bulging fontanelle, and breaking percentages. Your positive predictor value is going to be, it's 100% in that case. However, that's not how life happens. And so you can see in this Venn diagram that if you really have two or more findings, then you're on pretty solid ground that it's a failure. If you have one of these findings, it's a bulging fontanelle is pretty convincing that it's failing, but it's not 100%. So anyway, those are some things we're actively looking at, because who is a failure is not settled, and all these studies rely on failure. So anyway, that's where my talk ends.
So I think we'll open things up for questions while we wait for Dr. Drake to join us. I'll also thank you for bringing up the flexible versus rigid endoscope debate. We have an internal debate down here in Miami. I use the flexible endoscope because I trained with Dr. Worf, and everyone else uses the rigid endoscope. So we debate back and forth on the two scopes. The other thing I will add for CPC, though, the published data is up to 1 year of CPC benefiting. He's shared that with unpublished data, he thinks it benefits up to 2 years of age, but probably not beyond 2 years of age. So I think we have two questions from the audience so far. The first one we have is the SOP study compared ventricular reservoir versus subgaleal shunt. What is the current evidence for temporized via recurrent LP taps versus reservoir insertion?
Yeah, I mean, there is good evidence that it's a good short-term solution. You know, there's a Cochrane review of LP. And so typically that's on our algorithm is, so when they call us that, oh, we have a baby here with a grade 4, then usually they do LPs, 1 or 2 LPs. And if they need to keep going, that's when we pull the trigger to do the reservoir. So either the ventricles continue to grow or the patient gets symptomatic after the 2 LPs. The nice part about that is most of us work in a metropolitan center. And so if the patient's at an outside NICU, they can alert us, try the LPs, they're on our radar. And then after the first or second fail, that's when they come to the children's. So that's how it works at most of the centers, but not all.
Jay, a question for you, just a personal question from myself is, what age are you offering the preemie IVH population ETV-CPC? Are you waiting until the 6-month mark, or how do you counsel the families who come to you and say, oh, we've read about ETV-CPC and, you know, so-and-so is doing it, and why aren't you offering it to me?
Yeah, and I should add, everyone offers ETV-CPC up to the age of 2. But in terms of the exact question you asked, in preemie IVH, none, except there's that rare second bump. the kid that goes home, you follow them for a while, they were doing great. Oh, you don't need anything. You're contemplating taking the reservoir out, or you never put one in. And then they show up at 6, 8, 9 months of age. I didn't show it, but there is subgroup analysis in that paper that shows over the age of 6 months, corrected. So if they're 3 months premature, they're 9 months chronological, then they have a very high success rate with ETV-CPC, like 79%. So they're rare as hen's teeth. But if I get one of those, I do offer them ETV-CPC. But other than that, I've stopped offering preemie IVH patients ETV-CPC. Our success rate's 20%. It's just not high enough. So our threshold in the network is if you think you can have a success of higher than 40%, then we say yes. I don't know. We just came up with that number as a consensus. It's magical.
Okay. So there's another question from the audience that asks, with ETV-CPC, are there any age-related complications with lower CSF production, whether hypotheses or documented? Is there no, quote, significant concern of adverse effect of less CSF production later in life? Would be interested in hearing any of your hypotheses too.
Yeah, that's a good question. So if like Pat McAllister's here, he'd be like, his question number one is always like, does anyone else have a problem with burning a major organ in the brain, without knowing the long-term consequences in terms of growth factors, filtration, all this sort of stuff? I mean, we've been doing it now for how many years? 2005, so like 10 plus years. We're not seeing anything major in the first 10 years. We are comforted by the group in Bristol, had a group of people that they did CPC alone on, like an open CPC, and had followed them for 40 years. And they still haven't published this, but we've seen the data, and there's no higher rates in Alzheimer's, Parkinson's, or other Lewy body, any other dementias. And that's what that study looked at. So those two things comfort us. And the guys in Mbali and other places around the world that are doing 100 times more than we are not reporting any long-term like gestalt differences. And so jury's still out, but I doubt that there's a major change in cognition based on burning it alone.
Okay. All right. I think Dr. Wang has a question next there.
Perfect.
Great. Thank you very much. Thank you so much, Dr. Rivacambran, in delivering this wonderful talk. My question is also regarding ETV-CPCs. I was wondering how many centers in the HCRN currently do ETV-CPCs, and how many numbers do you currently have to work with?
All of the centers do ETV-CPC, and I think, yeah, all of them we have very specific criteria what you have to be signed off to do it. And yeah, when we last looked, we're accumulating probably about 120 a year. And I think we have a bank now. Last time I looked was a year ago, and that was 600. So it's probably more like 800 ETV-CPCs now.
Mm-hmm. And how many of those centers routinely obtain neuropsychological evaluations on these patients post ETV-CPC as a routine part of their follow-up care?
Yeah, 2 centers routinely do it, and about 4 others do it periodic. But again, you're probably selecting those that are having problems. But now that with the trial, they get a substantial, like they're getting neuropsych testing every 6 months if you're enrolled in that trial. But
Perfect. Thank you.
No, it's something else we should be doing in peds. We should be standardizing neuropsych, testing. Every child should get neuropsych testing at 1 and certainly at 5 years of age when you can do formal testing.
Yeah, absolutely. Great.
So hopefully more people in the audience will put your questions in. Just ask them through the Q&A function if you have any questions. I think another question we might as well raise is since one of the audience members asked about the role of lumbar puncture, what are your thoughts on the role of transfontanelle taps as well in terms of temporizing methods as one of the other ones?
Yeah, highly discouraged. I think their only role left is in an infected patient who you can't get an LP on and you need to do something, you don't want to put a reservoir in a child with a meningitis, like just do a one-off tap, and that's reasonable. Or that you can't get them to an adult guy, can't get him to a peds guy fast enough. Yes, and he's comfortable doing that, or she's comfortable doing that. But I mean, there's a Cochrane review that, you know, we don't have much in neurosurgery that is substantiated by a Cochrane review, and there's a Cochrane review that says multiple ventricular tap leads to encephalomalacia and an increase in CP and poor outcomes. So I don't know why we haven't implemented, you know, I would highly discourage multiple ventricular taps. A one-off, no big deal.
Jay, before you, so you said everybody has to get signed off through the HCRN for their ETV-CPC. So just if you could just recap, does that mean that everybody in the HCRN has to use the flexible endoscope, or is it permitted to do the rigid endoscope as well?
No, it depends. There's disciples of Wharf, of which I am, that it's all flexible all the time. But there's the other, I would say probably about 30% of people will go in with the rigid scope and do the ETV part and the septostomy, and then burn what's easy in the bodies. And then you have to bring in the flexible, scope to be a surgeon in the trial. So those people will finish the body, bring in the flexible scope, and do the temporal horns bilaterally. So that's the criteria now. And a significant amount of people do that. Just everyone's much more comfortable with the rigid scope. You got more tools to do the ETV. You can stop bleeders easier, that sort of thing.
Okay.
We also have a comment from the audience from Anne Flannery that Dave McClone had said the same thing about ventricular taps years ago, and she's glad to hear we now have evidence for what people thought previously.
Yeah.
So another question here is 40% chance of success for cutoff of ETV-CPC sounds high, especially considering that the success could be shunt freedom. Why not around the same percentage of the complications quoted?
Yeah, it's a great question. There's a knockdown, drag out battle when we talked about that 40%, just come up with it magically. It's just, I mean, I think in surgery, we tend to just talk about success, failure, and we always forget. I mean, I think that's reasonable because you brought up the complications, but, you know, these are not procedures without complications, it was just, we needed a cutoff, and we needed for the trial, we needed you to have a reasonably high chance of success, just to make it ethically, to give parent, to say, hey, there's two treatments. This one has a 90% success rate for sure in the first 6 months, and this one has a 4%. So we found groups of patients that we thought was close enough that ethically we could randomize them. So that's why we picked the 40%, basically.
We have another great question from the audience that's since the trial that was shown discussing entry site is not a significant determinant of shunt success, do you think it would be of interest to investigate shunt tip position? And did they look at that at all in that study?
Yeah, no, well, we did two very large studies. Like we looked at Bill Whitehead, this is in Texas, this is his baby. And so he went back, looked at entry site, combined that with shunt design, and one more study where we had great old randomized controlled data, and looked, and we were not interested in entry site at all. It was all about the tip, but it kept showing entry site, like the entry site would survive the model and the tip would fall out immediately. And then he did another study within the HCRN, and that's been published too, and the same thing showed in our data. And so the data said to chase entry site and not the catheter tip. And if you look at those, there's a big debate in the HCRN. We're going to publish it straight. I mean, the hypothesis was that there'll be a significant difference, but the p-value is 0.05. So anterior looked like it has a 17 to 20% advantage than posterior shunts. It just didn't quite make significance, but we will declare the trial that there's no difference because that was the hypothesis. But
okay. Does anyone else have any other questions? If not, I'm not sure if Dr. Drake got trapped in the OR, but I just texted and didn't hear back from him. So we may wrap it up if there aren't additional questions. And then I'll also share my screen so we have the flyer for our next Zoomposium. It's going to be in January, January 11th, and we're going to have Dr. Michael Scott and Dr. Ed Smith talk about Moya Moya. Both are at Boston Children's. Obviously, Dr. Mike Scott really has promoted the indirect bypass for Moya Moya and developed that over the course of his career. And Ed Smith is his mentee who's taken this over at Boston. So I think it should be a good discussion. They're going to talk a bit about when they decide to intervene, as well as some of the late-term complications after patients treated. So hopefully we'll have a good discussion that day as well. But is there one more question?
Dr. Riva. Yeah, no. Well, Dr. Riva-Cambrone, I just want to thank you for your time, giving us this talk today, giving us the update on the HCRN. We really appreciate it and look forward to seeing how things progress with the future trials.
Great.
Thank you very much.
Thanks for the opportunity. This is great.